Well, good evening, everybody. Thank you for that awesome introduction. And as David mentioned, I'm a volunteer with the Los Angeles office of the Arthritis Foundation, and I'd really like to thank Providence Little Company of Mary for inviting us to participate in this evening's event. As the introduction stated, I've been living with rheumatoid arthritis for over 40 years now, and my commitment really is to educate people and increase awareness, because a lot of people don't understand that arthritis does strike really at any age. So tonight I'll be presenting Discover Arthritis, Take Control, Exploring Arthritis Through Diagnosis and Treatment Options. So here's an overview of what we're going to discover tonight. First, some arthritis basics. What it is, how many people have it, and how it's diagnosed, and some of the common types. Next, we'll discuss pain, relief, and how arthritis can be treated and managed. You play a big role in that. And then I'll wrap up talking about resources that are available from the Arthritis Foundation to help people take control of their arthritis. So when I say the word arthritis, what parts of the body do you immediately think of? Knee, joints, hips, perfect. Those are all great examples of parts of the body that are affected by arthritis. And when we look at the word arthritis, it literally is, if you take it from its Latin roots, it means joint inflammation. And it's literally, arthritis hits the areas of the joints where the two bones come together. But it also doesn't necessarily, well, it affects the joints, but it can also affect the tissue that's around the joints as well. So let's talk about some facts and figures real quick. So can anybody guess how many people in the United States are living with arthritis? Wow, give him the gold star. 50 million is absolutely correct. And that's people who are living with doctor-diagnosed arthritis. So it's not surprising it's the #1 cause of disability in the United States, followed only by heart disease. So would anybody like to venture a guess as to what the normal age is?
48.
Good answers. So we know that it seems to be more common as we age. So it affects over half of the people over the age of 65. But what you might be surprised by is that actually more people are under the age of 65 who have arthritis. And as mentioned in the introduction, I actually have juvenile rheumatoid arthritis. So it affects kids also. So unfortunately, these numbers are expected to rise, and we expect by the year 2030 that number should be about 67 million people who will be living with doctor-diagnosed arthritis. And that'll be approximately 20% of the population. Okay. Does anybody want to guess what the cost is to our economy if we were to add in medical expense, the cost to the medical expenses, the lost wages, and other expenses? Higher. $86.2 billion. Yes, I said with a B, billion. So again, huge impact on our economy. All right, so let's move forward. Warning signs of arthritis. So only a healthcare professional can diagnose arthritis, so please don't come to me at the end of the presentation and show me your hands and say, is this arthritis? Because I can't diagnose. But what I can tell you are some warning signs or things to be aware of, okay? So the first on our list is pain. Now, the pain with arthritis is a funny one. It could be constant, it could be intermittent, it could be on one joint, it could be multiple joints. The next sign to look for is swelling. And some types of arthritis, the skin over the joint actually swells and it becomes warm to the touch. Next, your joints may feel stiff, especially when waking up in the morning or after sitting in the car for a long time. And then finally, you may just have difficulty moving your joint. So if you have any of these symptoms or any of these warning signs, for more than 2 weeks, I would get on the phone and call your health care provider and seek professional advice. So you may be wondering, what's going to happen when I go see my doctor? What are they going to look for? So the first thing I want to let you know is that with certain types of arthritis, it may take more than one visit to your healthcare provider before they are able to diagnose you. So please have patience. When you come to the doctor, he's going to do a symptom history. He or she will want to know, what's been happening, so he's got a better understanding of the way your body feels and when it feels the way it does. Next, they'll do a physical examination. They're going to look at your joints to see if there's swelling or any limited mobility. They'll probably run blood and urine tests to look for inflammation, and then they may also do x-rays or other sorts of diagnostic testing. Now, I don't know about you, but I know for myself, sometimes when I go to a doctor, I don't remember everything that I need to tell them. So we really recommend that you start journaling if you're experiencing symptoms so that you can provide that information to your doctor so that they can help better understand what's going on with you and then provide you with an accurate diagnosis so that you can become your own healthcare advocate as well. So now that we've talked about some of the basics about arthritis, let's talk about some of the different types. So in the beginning, you remember that I mentioned that there's over 100 different conditions and diseases that fall under the umbrella called arthritis. So some of the most common forms are osteoarthritis, rheumatoid arthritis, juvenile arthritis, lupus, and gout. So I'm not going to talk about all three of them or all five of them tonight because we would be here a long time. So I'm just going to focus on the first few. So with so many different types, though, I want to let you know that the Arthritis Foundation does have all sorts of educational materials that are available to you. And you can simply pick up the phone and give us a call or go to our website, which is filled with tons of evidence-based information and educational materials. So a large part of understanding arthritis is knowing what type you have and then seeking out the information and knowledge that's appropriate to the type of arthritis you have. All right, so let's move on to osteoarthritis, which is also called degenerative joint disease, or OA. It's the most common form of arthritis, and it affects nearly 27 million Americans. So what is osteoarthritis? So we've got a diagram of two joints. One's a normal joint, and one's a joint that has osteoarthritis. And I'm sure Dr. Riff will go into more detail about it. But if you look at a healthy joint, you'll notice that the ends of it are covered with a slippery substance that's called cartilage. And that cartilage is what has your joints move freely against each other. With osteoarthritis, what happens is over time, the cartilage begins to wear away. And then over time, the bone gets exposed, and that's where the pain starts happening for people. And with more wearing away, the bone could actually become deformed or abnormal and become spurs, and that's causing where the pain comes from. So osteoarthritis is usually seen in the hips, the knees, the spine, and the fingers. Have you ever wondered if there's anything that you can do to control osteoarthritis? So there's no single cause of osteoarthritis. However, there's several things that are connected with its development. And some things you can control, and some things are outside of your control. So first, we'll start by talking about what you can control. First on the list is weight. Being overweight puts more pressure on your joints and can increase the odds of developing osteoarthritis in weight-bearing joints, especially your knees. In fact, studies have shown that losing as little as 15 pounds can cut knee pain in half. Now, another thing, weak muscles can also increase your chance of developing osteoarthritis. When the muscles around a joint are weak, it's not being properly supported or held in place. And again, that can cause osteoarthritis. A lack of physical activity can also increase your risk of developing osteoarthritis. So staying active is very important. And physical activity is a treatment for many forms of arthritis. And then the last thing on our list is actually both on the can control and can't control list, and that would be joint injury. Because if you injured yourself as a child or were in a car accident, that's beyond your control. But there are some things that you can do, like making sure you protect your joints and do things to make sure that you don't injure your joints. Another thing that we can't control is age. I haven't met anybody who's found the fountain of youth yet. Our inherited traits, again, that's something that we really have no control over. So let's talk about another form of arthritis, and that's rheumatoid arthritis. And it's very common, and it's different and distinct from osteoarthritis. With rheumatoid arthritis, what happens is the immune system reacts against parts of the joint. These reactions could occur in various joints, including the ankles, the knees, the hands, the shoulder. Basically, what happens is the person's immune system attacks the joints. And when this happens, your joints begin a long-term breakdown of cartilage and bone. Rheumatoid arthritis affects about 2.1 million people in the United States. And since rheumatoid arthritis is an immune disease, it's also called a chronic or long-lasting immune condition. In addition to bone and cartilage damage, people with rheumatoid arthritis often experience symptoms such as feelings of fatigue, loss of appetite, I don't have that one, and a low fever or low-grade fevers. Unlike the gradual buildup of damage that happens with osteoarthritis, the joint damage that happens in rheumatoid arthritis begins usually within the first 2 years. And for this very reason, early diagnosis and treatment is essential to preventing the joint damage as seen in rheumatoid arthritis. The cause of rheumatoid arthritis is unknown. We really don't know what triggers it. But we suspect that there's genetic factors that are involved and play a major role in having the disease show up for people. The onset of rheumatoid arthritis usually takes place in middle age, people in their 30s and 40s, and also more women than men seem to develop rheumatoid arthritis. And then lastly, I'd like to take a couple minutes and just talk about juvenile arthritis. So did you know that we have over 300,000 children under the age of 17 living with juvenile arthritis? And the challenge with children who are living with juvenile arthritis is it varies. The diseases that are covered in this particular category vary greatly from child to child. It may affect one joint. It may affect multiple joints. It may involve common symptoms are swelling of a joint, stiffness, or muscle weakness. And because a child is developing, it's also very important that they get medical attention, because you've got not only the physical manifestations, but you're also dealing with developmental issues. So for example, because I've had my arthritis since I was 7, my lower jaw didn't grow properly, and my feet and hands are both small in proportion to the rest of my body because of the way it affected my joints. So it's very important that if you do know a child, or you have a child that you suspect who has juvenile arthritis, that you direct them to a healthcare professional, who's a rheumatologist who's specially trained in dealing with children. All right, so let's talk about what's important to everybody who's living with arthritis, and that would be pain control. And there are a lot of things that you can do and your healthcare provider can do. So let's talk about some of those things, which include hot and cold therapies, weight loss, physical activity, pacing yourself, and then some of the programs that the Arthritis Foundation offers. So applying heat or cold to an affected joint is one of the easiest ways to relieve arthritis pain and stiffness on a short-term basis. Now, what heat does is it relaxes the muscles, and it increases circulation to that specific area. Some good examples of heat would be a heating pad, hot packs, sitting in a heated pool or a whirlpool, and of course my favorite one, first thing in the morning, is taking a nice long hot shower. Cold, what cold does is it reduces swelling, and it numbs the nerves that detect pain. Some examples of cold would be using an ice or cold pack. You could even use a bag of frozen veggies. Now remember, do whatever's comfortable for you. The most important thing is that you're comfortable so that it reduces the pain that you're feeling. But I do want to remind you that when applying hot or cold therapies, you want to not exceed more than 20 minutes at a time on the affected joint. Allow it enough time to return to its normal temperature, and always wrap either the hot pack or the cold pack with a cloth around it so that you don't burn or freeze the tissue around the affected joint. Next, putting extra weight on your joints can cause more problems than you think. We know that as a person's weight increases, their risk of arthritis increases as well. Pain in the knees, hips, and back also increase as weight increases, and the levels of disability increase as well. So the good news is that if someone's overweight, losing just a few pounds can decrease the risk of getting osteoarthritis in their knees. One study found that weight loss of 11 pounds can decrease the risk of developing osteoarthritis in the knees, and weight loss of only 15 pounds can cut knee pain in half. And I can tell you, with the extra weight I've put on, I definitely feel it in my hips and my back. So don't follow my example. So a little weight loss goes a long way, but we also know that losing weight is not a simple process. So regular physical activity, such as taking walks during lunch, coupled with a wise diet, can help you lose weight in a safe manner. So the Arthritis Foundation does offer a series of self-management programs designed specifically for people with arthritis called the Programs for Better Living. And they've been proven to control and reduce pain through physical activity and an awareness of the disease. Each of these programs is led by an Arthritis Foundation certified instructor who has been trained to teach people the skills they need to learn to help them feel better. The Arthritis Foundation exercise programs are exercise programs designed specifically for people with arthritis that uses gentle activities to help increase joint flexibility and range of motion and to help maintain muscle strength. Different classes are available to fit your fitness level, with exercises done while standing, sitting, and even on the ground. The exercises you learn in class should not replace therapeutic exercises prescribed to you by a therapist. Participants who have previously been enrolled in our classes have experienced benefits such as increased functional ability, increased self-care behaviors, decreased pain, and decreased depression. In fact, this evening I've brought one of our Arthritis Foundation fitness exercise instructors with us, Victoria Johnson. She's sitting here in the front row, and she has been instructing for over 10 years here in the South Bay. And in fact, she leads classes up at the Jocelyn Center in Manhattan Beach and the Manhattan Beach Community Church. And she'll be available to answer any questions at the end of the evening if anybody wants to ask her about her classes. So I'd like to share just a little bit more about the Arthritis Foundation and what we do. The Arthritis Foundation is a nonprofit organization that helps people and as we search for the cure and the prevention of arthritis, and we teach people how to manage the symptoms associated with arthritis. The arthritis has many ways that you can get involved. We have listings of local programs throughout the greater Los Angeles area. So whether you're looking for a lifestyle change or just another person to talk to about having arthritis, we can connect you. I'd like to quickly highlight a few of the other ways that you can get involved. We work with our legislatures to let them know the importance of funding arthritis research and providing programs for people with arthritis. We currently are working with our elected officials to pass a bill that will strategically fund arthritis research, fund more doctors to take care of juveniles with arthritis, and provide more programs in underserved communities. And we encourage you, if you have arthritis and have access to the internet and email, to become an e-advocate with us. In addition, we also encourage people to get out and move. And just like riding a bike, people can exercise. And a great exercise for anybody, including those living with arthritis, is to walk. So we've discussed a variety of topics today, and it may seem overwhelming to you. But we do have a lot of different resources that are available for you. And you can go to our website, which is www.arthritis.org, or you can call our 800 number. Many of our resources and educational materials are available for free, and it's just a matter of picking up the phone and calling and letting the Arthritis Foundation know what type of arthritis you have, and we can send you a packet of information that's tailored specifically to your needs. And if you're newly diagnosed, again, you can call and ask for the Just Diagnosed packet, which has a wealth of information available for you. So if you have any questions, absolutely feel free to ask myself or Victoria, and we're more than happy to answer your questions for you this evening. Thank you.
Thank you very much. I'm very excited to be here. I really enjoy speaking about what I do. I think I'm very lucky because patients that come to me are in pain, and it's a challenge to relieve it, and we're very successful at it. So we're fixing things, we're making people better, and I think that's got it all over other areas of medicine and even surgery. And so that's a secret. Don't let anyone else know that orthopedic surgery is where it's at. I want to thank the Arthritis Foundation for supporting this talk and lectures of this sort that they support in the communities. And I want to thank Little Company for the opportunity of speaking to you again, and Ronil, who does yeoman's work in organizing these, supporting them, and taking care of every last detail right down to the last minute. And I really appreciate it. Without her, these would not happen. You've learned a lot about arthritis earlier. You've learned about conservative treatment for arthritis. And most of the time that you hear talks about the latest and greatest in any kind of surgery, or especially orthopedic surgery, someone is giving you a very technical talk about this type of implant, that type of implant, how you get into the hip, back from the back or the front. And we'll talk about all those, or why one implant has got a gadget that's different from another. And we'll talk about some of those things as far as the latest in joint replacement goes. But honestly, the thing that is really the latest is a concept of patient-centered care. And that we'll talk more about what that is. And that means that there's an organization about how your care is being delivered that begins early in the game and continues long after your surgery, that is focused on exactly what has to be done, exactly the same way every time, and precisely without there being room for error. That's becoming more and more the thing, and it's what we've been doing at Little Company for quite a while. So, joint pain can affect you in many ways, and you learned that. Symptoms: chronic aches and pains, feeling of heat or swelling, joint stiffness, joints that lock, meaning you can't move it, it gets stuck, sleep disruption because of pain, and you've learned that age, weight, what you do, genetics, abnormal body structure, meaning some sort of deformity, or repeated joint injuries can add to the risk of developing arthritis. And now we're talking about osteoarthritis, because what you did learn is that inflammatory arthritis, like rheumatoid, it really is out of your hands. I mean, that's a disease that happens, and it's related to genetics, but it's not, and it's worsened by weight and other factors, but it's not something that is related to what you do. You've learned already that 27 million Americans suffer from one form of arthritis or another. And you've also been told that if you feel that you're having a joint problem or suffering from arthritis, that you really need to see your doctor. And I like calling them doctors, physicians, that healthcare provider, or primary care provider, that's getting away from what we really do. So when you see your doctor, he'll do a medical history, meaning he'll find out what you experience, how long you've experienced it, whether you feel pain, stiffness, the very things that we discussed earlier. X-rays are important. They tell us whether or not your joint is wearing, and if so, how much it's worn out. CT scans are usually not necessary. Occasionally they might be indicated. MR scans are really not. And I know that the notion is that MR scans are the be-all and end-all of diagnosis, but in fact, plain, simple X-rays taken the right way of a particular joint tell the tale. And again, it's very unusual that an MR scan would be indicated for diagnosis of arthritis. Lab tests to rule in or rule out inflammatory arthritis, and generally to ascertain the level of health that you have. Osteoarthritis, I'm supposed to use this, rivals cardiovascular disease for the leading cause of a disability among the elderly, and that's a big statement. We've also learned about non-surgical treatments, because that really should be tried before you consider any sort of surgical intervention. And they include, as you've learned, exercise. I'm not all that convinced this makes much difference, but be that as it may, it can't hurt. Physical therapy is key. Being active, learning exercises to strengthen muscles which become weak because of pain and because your joint is stiff and so the joint doesn't move. Physical therapy helps you gain some motion if the joint is stiff, and more importantly, helps you get stronger, which makes a tremendous difference in joint support and your ability to function better. There's a classic orthopedic surgeon, long deceased, who wrote a classic article which was called "Don't Throw Away the Cane." Canes do amazing things to help relieve both knee pain and joint pain if used properly. However, when I say that, I'm always met with a grimace. I will not use a cane. But honestly, it really makes a difference, especially if you're not quite at the point where you're needing surgery. If we worked out the physics of it, and I'm not going to do that now, thank God, unless you want me to, putting a cane down on the floor on the side that is appropriate, which is the opposite side to your problem, whether it's a knee or hip problem, putting a cane down on the floor results in the forces going across the arthritic joint being reduced by at least a half, if not more, just by putting the cane down. And we can prove it with diagrams, but not now. There are medications that can be used, and arthritic medications, simple ones like Advil or Relieve, they're very good. Tylenol helps with pain, but it's not anti-inflammatory. There are long-acting NSAIDs, non-steroidal anti-inflammatory medications like Celebrex, Mobic, and others, which can provide long-acting relief, and they are excellent. I think patients sometimes are a little afraid to use them because of the concern about side effects, but in discussions with your family doctor, general practitioner, internist, you can determine whether or not, in fact, it is safe for you. Okay. And we've also heard that weight loss, exercise, etc., we've done that. We've talked about Tylenol, aspirin-free pain relievers, anti-inflammatory drugs, injections. There are two types of injections that can help relieve pain in an arthritic joint. Cortisone-like injections or steroids, and hyaluronic acid injections, which is a material that is often thought of as a lubricant, but it's not really. It's an extract from cartilage, in this case cartilage from roosters, and it can help relieve pain by forcing water and moisture actually into the cartilage you have. It hydrates the cartilage, and that provides some relief. It's usually given in a series of 3 or 4 or 5, whereas the steroid injections usually just require 1 injection. It's not a panacea, but all of these things can help stave off the time for surgery. On the other hand, there is a growing consensus that sometimes patients put off surgery really too long, or longer than they really need be, which is a shame, because the benefits of it are quite significant, and the latest techniques and the latest implants really are quite successful, and the risks are relatively small considering the benefits that you're going to have. We used to be more concerned about how long an implant would last, and that's why we would tend to hold off and encourage patients to wait, because we were thinking that, well, they might last 10 years. Now we know that our most modern implants put in properly can last 20, 25 years, maybe longer. So, when should you consider surgery? Simple everyday tasks are painful. You can't sleep. All of the treatments that we talked about simply don't work well enough to make you happy. Chronic knee inflammation or swelling and stiffness doesn't improve with rest or medication, and the same can be true for a hip or a shoulder. Now, knees can actually develop deformities. You don't notice that as well with a hip or with a shoulder, but knees can become bow-legged or knock-kneed, and can be mild or it can be significant, and that can result in additional disability. With hip arthritis, you often can't tie your shoes or socks. You can't move your leg, externally rotate, we call it, and bring your knee up to your chest, be able to do that. And the bottom line is, and I should have a slide that says it, what I express to patients is that when you're fed up, that's when you're ready. Literally fed up, when you just don't want to put up with the limitations you have, the pain you have, the stiffness you have, the medications you have to take, that's when you're ready. Latest hip and knee surgery. Okay, that's our big topic. We've talked about doing conservative treatment, and again, this is a summary of all those things we talked about. Bracing can be helpful with somebody that, for example, has a knee deformity, but it's short-lived and the braces tend to be pretty elaborate and uncomfortable. Patients that I've had that have sought that as a way of putting off surgery tend to keep them in the shelf in the closet. They just don't like them, and I don't blame them. But we can then think about arthroscopy. That's a potentially temporizing procedure where you stick a scope in the knee and see, and you don't do it if it's clear-cut, totally worn-out joint, but if it's early in the game, it might be possible to irrigate the joint, remove some worn-out particles of cartilage, fix torn meniscus, cartilages, and so forth, and result in a joint that is somewhat more comfortable for a period of time. Then when we get to joint replacement, we have various options, and we'll get into those, what a uni means, what a PFJ means, and a total, and so forth. That's if they don't, haul me off the stage with a big hook. Patient-centered care, and that's what I was talking about. It turns out that if you really count up the people involved in providing for your care in that whole spectrum from beginning to end that I was talking about, it's quite amazing. I think the slides possibly out of order, but we're talking about a team effort where everybody involved from beginning to end is part of the team that's going to help you get through this entire experience. And this facilitates having a smooth flow through the entire surgical experience, and begins with preoperative evaluation, the surgery itself, the follow-up rehabilitation, and helping you get back to your normal life. So the number of people in patient-centered care in the team, at least my team, includes my office staff, without whom I would be nowhere. The hospital admission nurses, who are like the last screener before you get in that picks up potential problems, or incomplete lab, or such as that. The hospital, the physical therapists. Now, before actually you get to the hospital, my team includes physical therapists that you see as an outpatient to teach you what to do afterwards. And at the same time, you're doing as much as you can, given your pain, to get strong and unstiff, because that does help. During the hospital stay, which is getting shorter and shorter in my hands, you see the hospital physical therapists who begin you on an exercise program, which is absolutely key. Once you get home, there are home health physical therapists who continue that same protocol of exercise and monitor your progress, coach you in your progress, and eventually sign off by the end of 3 or 4 weeks. At that point, it may be of interest and valuable to then go back to the outpatient physical therapist and continue to get stronger and more able to return to those things that you used to like to do but you couldn't before, whether it's golf or doubles tennis or swimming, long walks, hiking, and so forth. Back to the team. The case manager is really an unsung hero. She meets you when you are first at the hospital, and she's responsible for making sure and coordinating that all of your needs there and once you get home are met. Make sure that all your drugs are ready when you get home. Make sure that your durable medical equipment is the fancy word for walkers, stationary bicycles, and so forth, is all set up. There are blood thinners we use afterwards to prevent phlebitis. That has to be arranged and confirmed that, in fact, you have that available. Orthopedic nursing team leader is the leader of the entire team on the orthopedic floor, and fortunately, the leader of the orthopedic floor at Little Company is completely behind this notion of team building and being part of a protocol that starts early and ends way after, and has made it just delightful to work on the floor, to encourage her nurses to be focusing on exactly what the protocols are. If it looks like there's an error, they pick it up instantly. And it's very different from before, when nurses really were not sure what to do because every doctor does things differently. Here, I'm doing everything the same for everybody. It's easy. It's all written down, and nothing falls through the cracks. And if it does, we have ways of catching that. We have the operating room staff that numbers anywhere from 3 to 5 or 6 people that are helping you. There are the nurses that you meet first before you go to the operating room and say do surgery. There are the nurses in the recovery room. There's anesthesiologist. And there's the joint implant representative from the company whose implants I'm using. Ross from Zimmer is here. The joint implant people are invaluable. They're responsible for making sure that everything we need is there that day, that nothing has been left out, that we are able to cover any incident that should arise if it's unexpected. And they really are part of the team. And the surgeons last. I want to move over here. I hope you can hear me. Can you hear me? Is this working? Okay. I know nobody can see this, but I was kidding myself that I could write this and it would be of value. But the point is that this is the continuum. This is when you start getting ready for surgery. And we start this 28 days before your surgery date. And then this is 28 days after. This is the surgery date. And what I've done is I've marked all the steps along the way that are taken to get you ready and make sure that when this day comes, first of all, you know more about your joint replacement than anybody else. And we're constantly providing you with information throughout this whole period. We have your primary care doctor see you at least 3 weeks before surgery, and he does his routine tests. Now, some of those tests are designed to pick up problems that we might be able to resolve prior to your surgery so we don't have to cancel it. That could be culturing you for some germ that you've got in your bladder, culturing you for staph in your nose, and so forth. And we want to know about it, and we want to have enough time to treat it. We also have you then see the pre-op physical therapist, as I said, to learn these exercises and do them as best you can. By the time we see you, I see you in the office for the last time before surgery, about 1 week before, we check to make sure everything's ready, that we have everything, that nothing fell through the cracks, that you see there are always ways of checking and checks and balances and so forth, so that when you do show up the morning of surgery, it's smooth as silk. You see the anesthesiologist, he does his thing, you're then in the recovery room, the nurse is there, manage your waking up and start encouraging you to use the pain modalities or pain prevention modalities that are available. Physical therapy comes up in the recovery room to start you on the exercises because, you know, there's no one is allowed to be lazy. So right afterwards, we get you moving and you do as best you can. You're in the hospital, continuing those exercises for a day or 2 or 3, depending upon your situation and what procedure you have. Partial knee replacements, which is a very limited surgery, can go home the next morning. And now I'm going to be, because there's such great cooperation among all of these team players, we're going to be able to send partial knee replacement patients home the same day. Total hip patients uniformly go home the second day after surgery. And the third day is for patients who simply need more time. And nobody gets thrown out, nobody gets pushed out. And if you need more time that extra day, that's fine. But essentially nobody stays beyond that third day. When you're home, the home physical therapist shows up. They continue working with you as your coach on the exercise program. And that just continues through this 28-day period when their ability to see you ends. And that at that point, you're really doing all the exercises on your own. You know them cold. You've been working with the coach for a long time. If it turns out that you might benefit from some additional work with a physical therapist afterwards, and that tends to be more younger patients who want to get back to a more sporting life, as I said before, then we might have you work with the outpatient physical therapist and even get you involved in a really comprehensive strengthening program. And I've been using Pilates in concert with physical therapy as a great way to accomplish that goal. So anyhow, this is the idea of having this continuum of care that starts here, ends here, and is exactly the same for everybody. And all the team players know exactly what to do, and the end results they speak for themselves. All team members are encouraged to check on any deviation from the normal procedures. and this leads to fewer errors and more consistent results. The T model is efficient and reduces your stay. The T model makes sure your pain control is on target, because we're using newer concepts of how you manage pain-related surgery. It's called multimodal pain control. And we actually start treating your pain before surgery, because you can stop and reduce the amount of pain you have if you actually block pain pathways with medications like a low-dose narcotic, Tylenol, Celebrex. They all, taken together, result in less pain afterwards. And we start those oral medications immediately after surgery. And the end result is that since you're not on IV narcotics afterwards, pushing a button every time you feel pain, you're not nauseated, you're not tired, you're not sleepy, and you can be active and leave early. What are the surgical solutions? We talked about arthroscopy, which is marginally helpful, and I don't put that out as a key part of what I do, but for the right patient in the right situation, it can be helpful. Let's say you have knee arthritis. There are partial knee replacements, meaning that the knee actually is 3 joints. There's the kneecap joint, and then there are 2 compartments, one on the outer side of the knee and one on the inner side. And it's possible that only 1 or only 2 might be arthritic, not all 3. If only 1 is, it's possible to fix just that. That makes the surgery even smaller and with a much quicker recovery, and that permits you to go home the same day. Again, benefiting by the newer pain control techniques, which were now for them, couldn't happen. Then there's the kneecap joint, patellofemoral joint. Sometimes that becomes arthritic all by itself, and there's a procedure just to fix that. Again, you can leave early. Total knee replacements and total hips are the other options, and if that's what you need, it's very straightforward. I do minimally invasive surgery, which means that there's a smaller incision. With regard to knees, it allows us to spare the quad muscle and not cut into the muscle. That means less post-op pain, faster rehab. There's less tissue trauma. New pain control and anesthesia techniques, we talked about that. Rapid post-op rehabilitation programs, we talked about that. There's computer navigation. This is a gadget, which is part of a computer navigation device that, the simplest thing to say, it's sort of like GPS. It tells you exactly where you are. It's not GPS, it's not GPS based, but it's like it. So there's a mini GPS system in the OR, and without getting into the technicalities, it enables us to make the bone cuts that are key in putting the parts in properly that much more accurately. And I've used it for a long time, and I really support it. It also lets us avoid certain aspects of traditional knee surgery that result in more blood loss. And again, we could get into details about that, but suffice it to say that less blood loss, less interference with some of the potential risks of phlebitis and DVTs as a result. Navigation is good. Again, we talked about greater precision related to using navigation. Traditional knee replacement instruments involve using mechanical jigs, just like a carpenter and his miter box. Literally, it's just like that. And you can do pretty well, and I can do pretty well with those, and a lot of docs can do pretty well with those. But they're always what's called outliers. A cut can be maybe 2 or 3 degrees off this way, and the next one could be a degree off that way. Well, if you add up enough of those minor errors, suddenly you might have a big error, which then makes it an outlier. so that your knee is not quite aligned as well as it ought to be. And that tends to be not good. And with the computer, you can reduce those outliers, and you have more people ending up with closer to exactly where you want to be. In hip surgery, there's also the possibility of using computer navigation. It's a bit less clearly valuable there, but the position of the socket in a total hip is key. And it may be that it has a role in making sure that the socket is just right. I don't use it all the time. I can see the socket very well and use other anatomic landmarks to get them in correctly, but I've used navigation in it. In a tricky situation, it can be helpful in a hip as well. Also helps to get leg length more precisely at where you would like it, because that's always an issue, whether or not one leg is going to come out longer or shorter. So, knee surgery, small incision, spare the muscle, don't cut into it. New instrumentation, we'll skip that. But these are ways of doing what navigation does, just in different ways. So it's the same concept. We talked about partial knee replacements, and then there's the matter of gender-specific implants. It turns out that women's knees are different from men's knees, in their shape, in their proportion, and we've always had one type of implant. And we have tons of sizes to use, and we match the size to the patient right there in the operating room. But some of the matching tended to be a little bit compromised. And so if you have a gender knee, that accounts for those anatomical differences, and so that if we try both, like it's a woman, but I'll try both trials. In other words, it's not the real thing. It's a trial, and we have trials in all sizes, and I'll try the regular one, and then I'll try the gender one, and I use whichever fits. The problem is the gender ones are pink, and the other ones are blue, and I have to be careful to not tell the guy he ended up with a pink. I don't think women mind that much if it's blue. A partial knee looks like, see, this part of the knee has good joint space, that's cartilage. This side was arthritic. So this side was resurfaced with a metal implant on the femur bone part here, and a tibial tray, as we call it here, and then a polyethylene insert. Newer polyethylenes are called highly cross-linked. Now we have polyethylenes that actually have vitamin E embedded into it because it's an antioxidant. And we've learned that polyethylene lasts longer if it's prevented from being exposed to free radicals. Can't take me anywhere. If it's not oxidized, it will last longer. The cross-linking between the molecules helps it last longer. Putting vitamin E in helps it last longer. Packaging it in inert gas, not regular air, helps it last longer on the shelf, and also in you. So these can be quite thin and yet last as long as you need. This is a partial knee replacement for the kneecap joint, where the rest of the joint, you see, is intact. This is a good joint space, as we call it. There's good cartilage on both the femur and the tibia, and we don't have a film of the patellofemoral joint showing it arthritic, which might be nice next time, but this is a replacement for the groove where the patella moves, and the undersurface of the patella gets a plastic button, which slides along here. So that's another type of partial knee replacement. This is a total knee replacement, where both sides of the joint are arthritic. So the entire end of the femur bone is resurfaced. These are really resurfacing, not replacements. So the whole thing is resurfaced. Here's the button that resurfaces the patella. That's the same button that's used in the patellofemoral joint implant. And then the tibia bone has a bigger, larger tibial tray and polyethylene that goes across the entire joint here. So all three compartments this one, and the kneecap joint have been resurfaced in a total knee replacement. The incision for this goes from here to here. With the uni, it probably goes about from here to here. So it's getting pretty small. Okay, we talked about this. Women's knees are different. And this just goes into that. See, blue, pink. Okay, I didn't make that up. In hip surgery, the key thing about hip surgery, or one key thing, is how it's done. I don't mean good or bad, but whether or not you have a surgeon that opens the hip from the front of the joint or from the back of the joint. That's called anterior, posterior. This is lateral on the side. Posterior has been the method most surgeons have used for a long time. I've used anterior or anterolateral from way back because it's more stable. It means that the hip dislocates much less. The risk of dislocation is much less. You don't have to have the activity or motion restrictions that somebody with a posterior hip replacement has, like you can't bend past 90 degrees, or you can't keep your knees together, or it's very important on which side of the bed you sleep or lie. All those precautions go out the window with an anterior approach. So that frees up your activity immediately after surgery. You don't have to wear a wedge between your thighs and knees to keep your knees apart when you're in bed. It's truly a great advantage. So then there are different types of anterior hip surgeries. That gets too technical, but suffice to say that I'm doing a minimally invasive anterior hip approach. There's a small incision, doesn't cut through muscles or tendons. As a result, there's less blood loss, there's quicker healing. The stability is because it's anterior. And there's increased range of motion because of it being anterior, and you don't have to worry about the stability problem. All in all, there's decreased recovery time. Done this way, patients are often just on a cane after a week or two, and then can be off the cane as soon after that as they're not limping. So, this is what a hip looks like. There should be joint space there, but you see it almost looks like all one bone. But there's no black space around the ball. This is a very arthritic joint, and you end up with a socket, a ball in the socket, the femoral implant in the canal of the femur bone, and I'm sure you've seen pictures like these. Minimally invasive has to do with the length of the incision, but it really has to do with the amount of muscle trauma. I mean, skin is skin, and a bigger or smaller scar is one thing, but what really counts in terms of recovery is how little or how much damage or to the muscles underneath you've created as a result of getting where you want to get. With these approaches, there's less. Why this? Because really larger incisions are just not necessary. We used to do, I used to, in my fellowship, routine anterior lateral hip approach was 10, 12 inches long. And we just did it, and boy, you had great visibility of everything. But it became more clear over time that you simply don't need all that room. And you can accomplish the job with much less access as long as you have the skill to do it. So there's faster recovery for smaller incisions, less morbidity. That means it doesn't hurt as much, and you have fewer complications. Reduced cost, well, because you can get out of the hospital faster. And patients like it because it feels better, it looks better, they recover quicker, they're home faster. Do you divide or go between the muscles? Well, this enables you to go between the muscles. In traditional approaches, you cut things. In these approaches, you either cut less or not at all, spare muscle attachments. This is a diagram, just for fun, of the particular anterolateral hip procedure I'm doing. Anterolateral means it's a compromise between having it cut right up front, which is very popular these days, so-called direct anterior. I don't like it for a number of reasons. We won't get into that. But if you go right to the front side here, you can get great access with all the goals that you need and without some of the disadvantages of that direct anterior. Anyhow, there's this muscle. This is the anti-limp muscle that helps you prevent. This is the muscle that keeps you from limping when you're normal. This one is right next to it, and we go right in between here. This fellow resurrected this approach from history. There's nothing new under the orthopedic sun usually, and sometimes things fade away, and it takes somebody new and clever to go back and say, hey, wait a sec, this might really be a better way to do it. And that's what he did with regarding this approach, and then modified it so it could be done through an incision that's very small, kind of like here to here. Oh, see, he's in Germany. So when you learn this, you go to surgeons who've been doing it for a while, and I learned it about 8 years ago. But then it turns out that some guys actually get to go here and learn from the source. They wouldn't send me, Ross wouldn't send me, I was really annoyed. I couldn't get a trip to Germany. I don't rate. This is a cross-section and another view of the muscles and so forth. This is the root here. And you don't cut anything, you just slip your finger through here, get right down to the joint, just gently spread these muscles away from this, and you can do the whole job right through there. Don't do this at home. Okay. So anyhow, these anterior approaches, you don't have to cut anything muscle-wise. You have great visibility of what you need to do. The cup acetabulum is very easy. You see it, and that's why you don't necessarily need the navigation because you see so well. The femur, thigh bone is a little more difficult, but you can see it. The incision's this or even smaller. And we haven't touched the back of the hip, and so there's very low risk of dislocation. It avoids nasty things like arteries and veins. It avoids nerves, avoids splitting muscles, and we talked about this. That's a little redundant. Okay, the outcomes of this approach are excellent. The blue is supposed to be, well, it's not fair because we can't see it, it's dark, so I won't go into the detail, but basically these are statistics showing better outcomes with this particular approach as opposed to a more standard approach. Sockets are held in place by bone ingrowth in both the knee and in both the hip and part of the knee. So this rough surface is impacted into a carefully prepared socket bed of precisely the right size. Friction keeps it in place until bone actually grows into these little interstices, and then it's locked permanently. This is a ceramic femoral head, which is very smooth, even smoother than the cobalt chrome alloy that we use mostly, but in a young patient, this being smoother means even less wear of the plastic here, and therefore potentially a longer lasting implant. And here we talked about vitamin E infused polyethylene, even lower risk of polyoxidation, ceramic heads, higher polished surface quality. All of this together helps. How do these tie together? Strong team, latest pain control anesthesia techniques, latest surgical procedures, latest instruments, latest implants, and this all leads to quick recovery, less pain, better outcomes, more fun. What this all means, more fun, right here, fun. Thank you.